Hello, everyone. Thank you for joining the AAN Virtual Resident Education Lecture Series. Today's topic is how to be a cognitive neurology clinician. Keep in mind that all participants are muted. If you have any questions throughout the lecture, please use the Q&A feature and we will answer them throughout the talk or have time afterwards to answer them. Today, for our lovely moderator, we have Dr. Daniel Weber. He will be looking over the Q&A and making sure to communicate all of your questions and answers here to our guest of honor. I am happy to introduce today Dr. Joel Shenker. Dr. Shenker is an associate professor of neurology at the University of Missouri. After getting his bachelor's degree in psychology and biological biases of behavior at the University of Pennsylvania, he earned a PhD in biology psychology and an MD at the University of Illinois Urbana-Champaign. He did his neurology residency in the University of Virginia, where he was chief resident, followed by a cognitive behavioral neurology fellowship at the University of Florida. His clinical neurology focus has been in behavioral neurology, and his academic neurology focus has been as an educator. At the University of Virginia, he was neurology clerkship director. At the University of Missouri, he developed and taught an annual graduate psychology course in neuropsychology, and in the neurology department, he is in his 10th year as the neurology resident program director. For his role in medical student education, in 2017, he won the University of Missouri's Jane Hickman Award, the highest teaching honor in their School of Medicine, where he was also the 2019 commencement keynote speaker. He won the 2020 American Academy of Neurology Resident Program Director Year Award. Dr. Shenker, thank you so much for being here today. I am turning it all over to you.
Thank you, Ben, and welcome everybody. I'm going to share with you some thoughts I have about how I think it's wise to approach cognitive neurology topic as a clinician. And I'm using the word clinician very decidedly to really highlight how you should think about these topics from a very clinical point of view. And I want to try and make this very user-friendly, and that's the focus I'm trying to take as we discuss these things. And everything starts with finding out what in the heck you're talking about. One of the things I observe is that whenever patients are sent to me, almost everything is couched in the context of a word with memory, as if to imply that all cognitive problems are memory problems. But from a cognitive neurology point of view, memory is something very specific. It's only one kind of neurobehavioral function. It really refers to being able to recollect an experience. So if you can tell me what Sally said to you yesterday at lunch, that's what we refer to as memory. But all the things that occur as a result of experience are not necessarily things we should continue to use the word memory to describe. There are other topics, other domains we should consider. With respect to the narrow domain of only memory, we're referring either to negative symptoms or positive symptoms. Negative symptoms, of course, mean that something is lessened or something is removed. And the most common example of this is so-called anterograde memory problems. So your job as the clinician is to explore and find out exactly in what way is a neurobehavioral function not going well. You get that by talking to people, talking to the patient, talking to others, by your own observations, by whatever neurocognitive testing you do, and richly characterize what in the heck it is you're talking about. If people have anterograde memory problems, then that effort on your part tells you people aren't forming new memories well. This is the dominant feature, for example, in dementia diseases like Alzheimer's disease and some other dementia diseases where you get problems with anterograde memory failure. A remote memory that a person already has formed and already was able to recollect and then later loses access to is a different kind of negative memory problem. That's a retrograde memory problem, and that tends to be much less prominent in many of the dementia-causing diseases. Often not talked about are what we could consider positive symptoms of memory difficulty. You and I, when we have memory experiences, they don't really happen to us passively. You may have the, I'm arguing, wrong point of view that memory is just something that occurs, that you passively experience, something that happens to you. But in fact, memory is something you actively construct. Memory is something you build, and you sometimes do it incorrectly. In people with some memory disorders, they do it incorrectly even more. So they may take elements of different memories and congeal them together, or they may take things from other sources and put them into a memory of an experience, such as when a dream is now recollected as something that occurred, or something you hear on the television or on the radio, or you read in the newspaper, or something in a conversation now gets absorbed into an actual memory. So any of these different features can be part of a neurocognitive disorder presentation. Part of your job as the clinician is to identify which of these things is going on. It's going to help you characterize what you think the problem may be. A separate category might be having less access to semantic knowledge. What's the temperature at which water freezes, or the definition of words or other kinds of information, or basic knowledge about how the world works, or autobiographical knowledge about your own life or your family's life, or knowing things about the community. If you're losing this kind of information, I would not use the word memory. This is not so much a loss of the ability to recollect an experience, but it's semantic knowledge. And part of why I would make this distinction is your brain makes that distinction. And so your job as the clinician is to think about which parts of the brain are working well or not working well. That helps you to understand what kinds of explanations there may be. The neural networks that subserve semantic knowledge are different, partially overlapping, but different from the neural networks that subserve the ability to recollect, form a memory of, and then recollect an experience. Language, of course, is another very important neurobehavioral function that is also distinct from the other neural networks we've already considered. Very often, patients will say they can't come up with words. By itself, that alone is a fairly non-specific thing. You and I do that all the time, where you have that tip of the tongue phenomenon, and you're saying, gosh, what's the word for? And you're snapping your fingers, what could it be? Or who was that actor who blah, 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 blah. It might be a word you really should know. It might be a person who's really well known to you. A single instance, or even many of such problems, doesn't in and of itself constitute a neurobehavioral disorder, but it's one of the things you should think about. Sometimes what a person will do is to talk around a word, circumlocution. They may, instead of saying the word, talk about the information so that the other person in the conversation understands the word. Again, this is somewhat nonspecific. You and I do this all the time when we can't come up with the word we're trying to say. Paraphasias, however, are a little more specific to a language disorder. This is a naming error. You're trying to come up with a word, and the word you come up with is not correct, either because there's a sound you put into the word that doesn't belong there, or because you use an actual wrong word. It's not the right meaning. A neologism, a made-up word, or a word that's an actual real word, but not quite the one you actually meant to say. As you know, many people have a problem that's not just with expressing language, but being able to come up with an understanding of language that they are receiving. That could also be in the form of dyslexia, where they can't read. And of course, there can be problems with writing. Any of these things are things you want to try and explore and understand if any of these things are happening in a patient. Higher sensory functions are also things you can think of neurocognitive domains. It's not a memory problem when you don't recognize people, or at least it may not be a memory problem. It may be with the ability to put together the percept, to put together an understanding of who is this person. I see these sensations, I see this face, or I see this object, or I can touch and smell this object. And you may have the sensory information, but the higher sensory processing may have failed. And this is one of the things you need to explore as you're trying to understand what may have failed the person. Being able to see the forest or just the trees is also an important thing. There is a phenomenon called simultanagnosia, where the problem is a person can't form a percept when you have to have simultaneously many different things together. So if you have to be able to see several different elements of a scene for the entire scene to make sense, someone with this problem just sees the individual elements and not their simultaneity. Not being able to see the forest, only able to see the trees, is an important kind of specific syndrome that can occur. When people have a hard time finding out where to go in town, or when they can't quite navigate spaces, this is an example of a higher sensory processing problem that can occur. This probably underlies a lot of walking problems and falls in such people, because after all, your ability to be able to get around in space and move your arms and legs in space requires perceptually processing spatial information. And of course, some people may have hallucinations or illusions or other sensations that actually don't belong, but they may perceive them. So these are another category of problems you need to explore and understanding if any of these things are occurring. Not only can you have higher processing of sensory input, but there is higher processing of motor output. Our motor systems, as you know, certainly involve a lot of different systems of the nervous system that allow muscles to contract. But movement requires a whole lot more than strength. And for that matter, a whole lot more than coordination. You have to have an idea of why you're moving, what you're moving for, where in space you're trying to direct a movement. At the highest level, this has to do with being able to make learned, skilled movements, like making a salute, or knowing how to use a pen, or playing a piano. Having difficulty doing these kinds of tasks when that fails is a kind of apraxia, a loss of praxis ability. Sometimes that's simply knowing the steps of a task. And again, you get, as the clinician, you get this information by asking some good questions and by making some good observations. And you need to do that so you can understand which neural networks are implicated and have a better sense, therefore, of what the possible causes might be. Much is made about the concept of executive function. We should stop and pause a little bit about what is this domain? What is executive function? And the phrase is obviously very metaphorical. It's referring to sort of the executive of a company. You think about, what does the executive do? What does the president of a company do? The president of a company isn't working the factory line. The president of the company is not pounding the streets with a bell and a signboard to try and sell products. The executive is deciding things for the whole company to do. And of course, if the company is doing exactly what the executive wants, the executive may say nothing, may say, good luck, folks, keep doing it. So the executive decides when to continue the momentum of what's otherwise happening, and the executive decides when to back off and go into a different direction. So metaphorically, from a neurocognitive point of view, we can conceptualize executive function as the person's ability to impose their will against the momentum of what otherwise would have happened, to take in information, to use judgment, and decide what to say or do or think or feel next. That's very hard to do. It requires keeping a lot of balls in the air all at once. So you have to be able to divide your attention. You have to be able to sustain vigilance, being able to continue to be on the lookout for when a signal finally occurs against a backdrop of noise. It means you have to be able to handle several tasks at once and make plans, set priorities, and know what things to approach and what things to act on and what things to avoid. People with executive dysfunction may do some of this badly, or they may not do it at all. So a person might engage and make decisions and act on things that they shouldn't act. Such people might be disinhibited. Or a person with executive function may be like a bump on a log and may do very little. So you can have executive dysfunction that can look very different depending on how people respond to their executive dysfunction. This is another domain. And finally, you should consider about whether a patient has a problem with what we can call social cognition. This is an interesting concept that's emerged in the last few decades. And the idea is that social creatures need to be able to construct, comes from the pediatric psychology literature, The concept is theory of mind. You and I have a problem when we engage in a social interaction. And the problem is, I don't know what's going on inside you. I don't know what you know. I don't know what you're about to do. I don't know if you're a friend or a foe. So it makes sense, in order for me to capitalize and benefit from our social interaction, it makes sense for me to have ways to guess and to know as much as I can about what you know, what you feel, what you think, what you're going to do. In other words, I have to construct a theory of your point of view, of your mind. And the hypothesis is that there are brain systems that give us that capacity, that give us that functionality. Systems which, therefore, if they're present, can also fail. And when they fail in neurologic diseases, you can expect that person to have social cognitive difficulty, such as, for example, a person with autistic spectrum disorder, or people who have so-called personality changes with neurodegenerative diseases or after traumatic brain injury. They may come across as very not empathetic, when in fact what's really happening is they just can't construct a theory of mind very well. Some things that you and I do in order to navigate socialness is we establish norms. So as we spend time in groups, groups naturally start to do certain things and establish norms of who should do what and who should say what and what the rules are, sometimes, most of the time, without even talking about these things, without even vocalizing them. And you know these things intuitively, without even knowing that you know them. For example, if you go into an elevator, there's all kinds of rules about what you're supposed to do and not do in an elevator. You space yourself out, you put your arms down in front of you and or at your side, you don't move around very much, you talk in hushed tones, you all look up at the top of the elevator, they look at the numbers as if it's very enticing and important. You all know the norms. And by having social norms, it allows us in social encounters to be able to predict what another person's going to do. It allows us to navigate social encounters. So this may be the thing that fails. And when it does, you may observe, or family and others may report to you, that the person is behaving badly. But the badness of their behavior may have to do with a loss of social cognition and not mean or unkind decisions. Part of the story you need to get is a timeline. It's incredibly important to know when the neurocognitive problems began and how they've behaved over time. Notice how everything I'm trying to develop here is, you can't simply get a patient and see on the tagline of the reason the patient is seeing you, it's memory issues. But what does that mean? It doesn't mean anything. I need to get a sense of the story. What exactly is the problem we're trying to explain and understand? And in addition to characterizing it qualitatively, as I've just outlined, you need to characterize other things, including how did it start? Did it occur around particular seminal events, or has it changed over time around seminal events? The death of a person, the change of a job situation, the moving from one place to another. For example, a common thing is that a person is performing less well cognitively, but it's because they're actually doing a harder task. They now have a different job, or they have more people living in the house distracting them, or other things, so that what's changed is not their neurologic native capacity, but what's changed is the ask being made of that capacity. Is this a problem that's continuing, that's worsening, that's getting better, or is it occurring episodically? Is it getting worse over time or better over time? What's the overall duration? All these things are very important. Notice how if you were able to get all this information, and if it was able to establish to your satisfaction that all the cognitive problems have just occurred over the last month, you keep everything else about the qualitative story the same, but you say it started a month ago, and you're confident and sure that it's really only a month old. Now, all of a sudden, those qualitative features of the neurocognitive presentation can't possibly be from things like Alzheimer's disease, which takes much longer than a month to reach a point where there are symptoms worthy of your attention. Just knowing the timeline alone All these kinds of things gives you a huge amount of information on which you are going to make decisions about diagnosis. Another very important thing is to distinguish between whether someone has lost their capacity or they're just performing differently because of the context. That's where you have to get examples. You have to talk to people who know the patient, who can tell you about what's going on, or you acquire them by following the patient over time. You have to know about mood problems, anxiety, situational changes that I've just alluded to, such as a change in living situation, other people in the home, job changes, family changes, things like this. Very commonly, medical stressors are the reasons for cognitive performance problems. So you might have just as good a brain as you ever did, but it's stuck in a body that's having other symptoms. Chronic pain is a common example of this. It's very hard to use good thinking when you're in pain. So it's really not a fair fight to say you don't recollect the conversation yesterday when you were having a lot of pain, because when you're in a lot of pain, you don't really have a lot of attention left over to pay attention to a conversation well enough to then recollect it later. This is part of why chronic pain patients, fibromyalgia and other chronic pain situations, so often talk about cognitive complaints, the famous fiber fog. Medications very often can interfere with cognitive functioning. Anticholinergic medications, for example, or drugs like topiramate. And don't forget that things like sleep apnea, other parasomnias, insomnias, and such can interfere with your sleep, so that during the day you have bad cognitive function, in part because of fatigue and also because of the cognitive restorative effects sleep was supposed to have given you that you now lack. Very important for the designation you're going to give the patient is whether there are functional consequences to the cognitive problems being described. At some point, you're going to have to know, both because you want to help the patient, but also because it helps you label the clinical state. You're going to want to know, are they functionally affected by the difficulties that are being discussed? There are various survey-based ways to do this, but I like to begin with a simple question. What function can you or can your loved one not do because the person is too, in the case of a memory problem, forgetful? It could be a language problem, an executive function, whatever it may be. But because of that difficulty, what function is affected? And I find asking the question this way tends to get me good information to help me decide if there are functional consequences. So that's the first step. Please spend time getting a good sense of what is the story of the problem. And I want to emphasize that story is not simply the history that you collect by talking to the patient and the family, but some of that story is what you observe. Your observations as a clinician help you to distinguish between all those different things I've tried to describe and characterize. And notice that as a clinician, the things I just described there are really not all that complicated. You just take the time to think it through. It's so often the case that all I'm really doing as a cognitive neurologist is taking the time to have some conversation and do some observation. And these are vitally important skills as a clinician. Next, then, you have to apply the correct words. It's important to use the right words for the right meanings. And I find that a lot of problems happen when clinicians and others use wrong words, and now we're not communicating the way we need to be. So let's talk about what the words are. First of all, we've always had in neuropsychology and neurobehavioral syndromes, we've always had words that are very specific to a very specific kind of limited, narrow problem. For example, if you truly have a problem with memory and nothing else, we already got a word for that. It's called amnesia. If you have a problem with language and nothing else, we call that aphasia. If you have a problem with higher organization of movements, we call that apraxia, and so on. So the problem comes up then, what do you do if a person has an amnestic disorder plus a language disorder plus a problem with praxis? You could combine all those words. You could say they have amnestic, aphasic, apraxia, but it gets too cumbersome. And that's when we came up with the word dementia. That's really all the word means. It means mentation, taken away. Dement. Now, our friends in psychiatry use this book called the Diagnostic and Statistical Manual. Currently, we have DSM-5. And at some point, they dropped the word dementia and began to suggest this phrase, major neurocognitive disorder. So you now see this phrase creeping into clinical notes and in the literature, but really semantically, they are the same. They're referring to the same concept. Now, what do we mean by the word dementia? How do we define it? First of all, this is from the Alzheimer's Association website, and I took this screenshot a year or two ago. It's a little bit old, but this is the quote from there. Dementia is not a specific disease. It's an overall term that describes a wide array of symptoms. Saying dementia is like saying you have a sore ankle or a rash. It says something, obviously, but in and of itself, it is not a diagnosis. Rather, saying dementia is saying this is the thing you now need to diagnose. You need to diagnose something about that thing, but it itself is not a diagnosis. So what are the features of the definition of the word? First of all, it's important to understand that dementia is a clinical state. Dementia is not established from a test. Dementia is not established from an imaging scan. You don't get a chest x-ray and say, this chest x-ray tells me that this patient has chest pain. Chest pain is a clinical state. The patient tells you that they have chest pain. So in a sense, the story of the patient's problem is what tells you that dementia is going on. It comes from what the patient and the family tell you and what you observe as a clinician. So here's the features of the definition. Dementia is by definition an abnormal state, not just that your mentation is less good than you want it to be, but it's abnormally less good. It's acquired. It's not the way you've always been. Doc, I've been forgetful my whole life. We don't use the word dementia for that. You have to ment before you dement. The acquired abnormal problem has to involve multiple areas of true, actual, objectively measured impairment in neurocognition. Not just that, gosh, I feel like I'm less sharp than I used to be. The clinician has to do some assessment. Could be observation, but it's better if it's a objective, standardized, validated instrument that establishes it's not just that the person feels worse, but they are abnormally performing, cognitively speaking. By convention, although I would argue it's not necessary, but by convention, we use the word dementia if this abnormal acquired impairment, true impairment, in multiple aspects of neurocognition is due to a brain problem, as distinguished from times where you're performing poorly, but it's not the brain's fault. The brain's the victim. It's not the cause. By convention, we use the word dementia if the problem's been going on for a while. So if you're having a bad day or a bad week, we don't use the word dementia, other words. And by definition, finally, the person is functionally impaired. That's why it's important to get one of the reasons it's important, to get a sense of whether the person's cognitive difficulties are impairing their ability to function. So if a person has these 7 things, then as the clinician, you can say that the word dementia now applies. Which now begs the question, what if they have 6 and not 7? What if a person is well adapted? They have abnormal, acquired, multiple areas of true cognitive impairment. A brain problem is the cause and it's lasting a while, but they're still getting along okay. And that's when the phrase mild cognitive impairment was first suggested in the early 1990s. And the DSM formulation in psychiatry prefers the phrase minor neurocognitive disorder. So it's the same idea, except we're getting rid of the functional impairment part. Now, it is often, but not always the case, that people with MCI progress to a state of dementia. On average, that occurs a little less than 15% of the time in a 1-year frame of time. But of course, whether that happens depends on the cause. You can't simply designate someone as having MCI. As with the concept of dementia, you want to then have an etiologic diagnosis. And a final category we should consider is this entity of subjective cognitive decline. This is a phrase that's been arrived at in the last decade or so to capture people that have these features. People who themselves observe, it's a self-reported phenomenon, that they have marked, not just a little, marked decline in mental function. They say, gosh, I can really tell I am just not the person I used to be. It's really clear to me. I can really tell my word finding is worse. My ability to recollect experiences is worse. I can't do multitasking. It's clearly much worse, whatever the thing may be. It's not otherwise, however, as the clinician explained, it's not tied to an anvil falling on their head like in cartoons, or the day that you started them on a particular medication. And then you do formal testing and they test that okay. This is subjective cognitive decline. And in the old days, I would have called such people the worried well. But conceptually, that's a mistake. Because if you think about it, the cause, depending on the cause, if I go from normal to cognitively impaired, I don't get there in a day. And I may transition between times where I'm not as good as I used to be, and I'm not yet impaired, but I can tell I'm not as good as I used to be. So some folks who actually are destined to earn a designation of mild cognitive impairment or dementia will go through a phase that we should call here subjective cognitive decline. To how often and to what degree should we be concerned? Here's a meta-analysis from a few years ago that put together 28 studies, not quite 30,000 patients, average age just a little over 70, followed over an average of not quite 5 years. And what was discovered is most people with subjective cognitive decline 5 years later, most people are okay. Most people still would not be called mild cognitive impairment or dementia. About 1/3, however, will be, and that's about twice the rate of age-matched controls. So if you have subjective cognitive decline, it essentially doubles the risk of transition, doesn't determine it, but it increases the risk of developing mild cognitive impairment or dementia. So these are patients that should be watched, but watched fairly loosely. So now the designation is that we have people who may have a disease process that one day may cause symptoms, but has caused no symptoms at all. Some of them will then go on to have subjective cognitive decline, and depending on the underlying cause, may subsequently develop mild cognitive impairment or some stage of severity of dementia. So again, in a etiology-specific way, people may progress through these different stages. And the goal is, as these patients start to be understood better, is to be able to identify people when they're at a preclinical stage, and then intervene and do something so they don't again go through these stages. In the past, we've mainly only seen patients in these stages, and we're trying to get people higher up. The clinically diagnosable zone, I would say, is still here. Very mild patients are hard to distinguish from each other clinically, and very severe patients are hard to distinguish because so many overlapping signs and symptoms occur. The separate individualized pathways are more apparent when people are minimally symptomatic. Then we have to transition to think about what might be the underlying causes. And the main message, of course, is you've all heard of Alzheimer's disease, but it's not all Alzheimer's disease. Here's an old paper. So it's it's about 20 years old, in which patients who presented to dementia clinics or memory disorder clinics throughout the state of Florida went to autopsy. So several different places, and a sample of, I think it's about 300 some odd patients were assessed to see how many had Alzheimer's disease pathology at autopsy, how many had Lewy body spectrum or vascular dementia concluded, how many had frontotemporal degeneration, and how many had hippocampal sclerosis of aging. And the take-home messages are these. A fairly large minority of patients had Alzheimer's disease and absolutely nothing else. So notice that it's not even 50% that had pure mono etiologic causes to dementia. Then another large chunk of people had Alzheimer's disease, but with other things. So if you do the math, 42 plus 35, 77% of patients have Alzheimer's disease, but almost half of them, not just Alzheimer's disease, they have multiple diseases. And not to be forgotten, not quite a quarter of patients don't have Alzheimer's disease at all. So whereas Alzheimer's disease is certainly quite common, you should avoid the lazy presumption that everyone with a dementia has Alzheimer's. In fact, a fairly healthy number of people have a non-Alzheimer pathology in their brain, either as the only pathology or as another contributing pathology. So whereas you should think about all kinds of different things, but most of the diagnoses from an etiologic point of view are going to be Alzheimer's disease, vascular dementia, a frontotemporal degeneration variant, one of the Parkinsonian dementias, or one of the more newly described entities. These different things will constitute certainly well over 99% or so of all the patients that are evaluated for a neurocognitive disorder. Next, let's talk about how you decide on a syndrome. And I'm using the word syndrome here very, very carefully. I don't want to dwell on what the word syndrome means. And I want to defend my subspecialty a bit. Cognitive neurology, I will be a bit defensive now when I share. But I think cognitive neurology gets beaten up a bit. People will say, gosh, you can never decide on things. It's too complicated. Well, hold on now. Let me explain. This is a quote from last year's Academy meeting where a presenter made this comment, and I agree with it. In recent decades, she said, we've moved away from purely clinical taxonomy to a clinico-pathologic entity. In other words, in deciding on a cognitive neurology diagnosis, we are considering clinical features and we're considering pathology, a lot of different stuff together. And I thought about that. And I realized that really the point she's making, and the point I want to make to you here right now, is what we're talking about is a syndrome. Now, as many of you know, a syndrome refers to a time where there is no one single thing that makes or breaks a diagnosis. In a syndrome, there's a constellation of features that may be present. And some features may be present in one instantiation, but not another. But there's enough overlap that we think we know what we're talking about. Now, I would argue that's not just true of neurodegenerative diseases. That's not just true of neurocognitive disorders. It's true with a lot of things you already understand, you already agree with. And as a metaphor, I'm going to use the concept of an apple pie. I want you to think of an apple pie as a syndrome. Now, you and I have seen apple pies. And I'll bet if I asked you to go in a store and come out with an apple pie for me, I'll bet you would get it right virtually every time. And I bet you wouldn't come out with a pair of socks and say, this is an apple pie. And I'll bet you wouldn't come back with an apple pie and say, this is a can of detergent. You would get it right. But I defy you to give me a single test that always establishes whether something's an apple pie or not. All of these things are apple pie. You can argue about our friends at McDonald's whether it's real or not. Put that one aside. Sometimes apple pies are hot and sometimes they're cold. Sometimes they're round and sometimes they're square. Sometimes they're a slice and sometimes it's a whole pie. Sometimes it has a crumbly top or a hard crust or a latticed crust or no crust at all. Sometimes it's sweet, sometimes it's tart, so on and so on and so on. Apple pie is a syndrome. And we humans use concepts all the time. We navigate the world of concepts and we do it very, very well. So it shouldn't be an indictment or a criticism of a medical diagnosis that you don't have one single specific sine qua non test that always establishes that that syndrome is present or always establishes what a diagnosis is. You're already doing this. You're already considering clinical pathologic entities, syndromes, in all kinds of other ways. And we do that in neurocognitive disorders as well. Here's another very important point. I would argue, I titled my talk, I use the word clinicians. I want you to think about what a clinician is. This talk is intended for residents, for people who are learning to be clinicians in neurology. But I would argue that even more generally, whether we're talking about neurology or any area where we require clinicians, what does it really mean? What do we need a clinician for? Well, here's what I think we do not need clinicians for. A computer can do this stuff for us. Our patients can do this stuff for themselves in many cases. Passively record a complaint, order or do a medical test, simply assume that whatever the test tells you will be the cause and the explanation for the complaint, and then execute some consensus criteria that a group of experts got together in a Hyatt hotel somewhere and voted on and said, whenever this test shows such and such, do this or don't do that. If these 4 steps are all that people think clinical medicine is good for, we don't need a clinician. It's all passively decided before that clinician ever walked in the room. In fact, increasingly, patients can do these 4 steps all by themselves. You don't need to come to see me as a physician. And those of you who are studying and learning and trying to become clinicians in something, this, I'm arguing, is not what you're getting your training for. We don't need you for this. You are too expensive a commodity to have to be spending it for these fairly simple, straightforward things. Here's what we need clinicians for: to get a story, to do the work of asking questions, of making observations and understanding what in the world you're getting that story for, how the story might behave so you know what questions to ask. And then to think about the story. What does it mean? What did I just see? What syndrome is this trying to tell me about? Is this apple pie? And then making a decision based on your experience, based on judgment about what, if any, other data to get in the form perhaps of a test, an imaging scan, a lab value, a spinal fluid assessment, an EEG, or not. But we need a decider. We need a thinker, a person who has experience and judgment to tell us what in the world to do and when to do it and why and what you're going to do with that information. And then to apply judgment about all this. Here is what we need a clinician for, not just in cognitive neurology, but anytime clinicians are involved. If you're not doing this, I would argue you're not doing what a clinician should do. And I would argue we don't need you. We don't need someone who's highly trained and has high experience. We can get computers and artificial intelligence to do the things that we don't need clinicians for. Finally, let's apply what I've just described to the specific example of syndromes in Alzheimer's disease. It's important to understand that the pathology we call Alzheimer's disease can manifest in several different ways. We have early onset Alzheimer's that tends to behave differently than the more typical Alzheimer's disease, where symptoms come on as people get older. The artificial cutoff between early onset and late onset is the age of 65, which now that I'm 60 years old sounds increasingly young to me. One variant, the posterior cortical atrophy variant, has some unusual features that behave differently depending on which parts of the brain tend to be more affected. There's another variant that's mainly going to give problems with language, one of the so-called primary progressive aphasias. There's different kinds of primary progressive aphasias. There's one variant that is generally thought to be a reflection of Alzheimer's disease pathology as compared to other variants that may affect other pathologies, especially the disease frontotemporal degeneration. And finally, there's a frontal variant where there are predominantly executive symptoms problems, and there are not usually problems with memory that are so apparent. Now, I'm not going to go into all these. I just want you to understand that there are many possible syndromes that Alzheimer's disease can present with, and your job is to try and decide how the story of the patient's problem is evolving so that you can understand what syndrome best fits. But you can mostly capture at least the clinical behavior of those syndromes using clinical assessment criteria described in that paper I just showed, and summarized with these boxes. If you're describing the dementia from a classic Alzheimer's syndrome, the dementia has the features of dementia we've discussed. So basic activities are affected. The ability of function is affected. The person has a decline from baseline. It's not simply during a delirium. It's not only occurring during a delirium or with respect to some other psychiatric problem, which is one of the reasons why I feel that many of the dementia-causing diseases are not easily diagnosed in an acute care setting, such as a hospital, where you have competing possibilities that these other things may be going on. There is an description of cognition being worse by history. The patient or an informant tells you, this is not the way Sally used to be. Sally is different. There's objective testing that establishes there's impairment, and the impairment is at least in two different domains. So if the person has the features in this blue box, then they enter the algorithm. And it has inclusive features. Alzheimer's is not a diagnosis of exclusion. It includes that the symptoms came on gradually, and the initial and most prominent symptoms were one of these four things. And it has exclusionary features. The patient does not have at least a very substantial amount of cerebrovascular brain damage, such as having severe cerebrovascular damage on imaging or a stroke occurring at the onset or at each interval of worsening of symptoms. There are not prominent signs of one of the non-Alzheimer's syndromes, and so there's not another active thing that would be causing cognitive impairment. People meet these clinical criteria, are part of, but not yet definitional to the syndrome. How do we decide about Alzheimer's disease at autopsy? Well, Alzheimer told us about that. There was a guy, name was Alzheimer, Alois Alzheimer. And here's the English translation of his 1907 paper, which he thought was a weird, strange, unusual disease. Peculiar, said he, not your everyday diagnosis, but something that he thought was so unusual, it was worthy of publishing this paper. Unusual, said he, because the brain was very atrophic at autopsy, and it had a deposit in the cerebral cortex of a peculiar substance and peculiar changes of the neurofibrils. We're going to capsulize these three features of what Alzheimer described as loss of neurons, amyloid plaque, and neurofibrillary tangles. When you have a dementia disease, and at autopsy you have these three things, that's what allows us to say the syndrome of Alzheimer's disease is supported. But you have to have the behavioral part of the syndrome, and you have to have these three things. Let's spend time with each of these three things. So we infer the presence of dead and missing neurons in a living patient by looking to see that there's volume loss, not just volume loss, but in particular regions when we image a patient. So for example, on these coronal T1 sections, we can see that at least in a classic Alzheimer patient, here outlined in red, the hippocampus and the mesial inside parts of the temporal lobe are disproportionately more atrophic than other areas. We can see in axial sections that a person more and more affected with Alzheimer's disease is that severity is somewhat correlated with the degree to which the mesial temporal lobes and the hippocampi in particular are missing neurons. Some centers are starting to do volumetric measurements of the brain, where in a nice way they can give you feedback about the at least volume measurements of different brain regions, including, as the dark green shade shows here, the size and the shape of the hippocampus, to help rule up, not rule in, but rule up whether the story, in this case the radiographic story, fits best with Alzheimer's disease or with other neurodegenerative causes of neurocognitive disorders. The second neuropathology feature of amyloid plaque was first described in the early 1990s as possibly being etiologic in Alzheimer's disease. And the idea is this: a cascade of events creates amyloid plaque, starting with chromosome 21, which contains the code for making a protein called the amyloid precursor protein, which sits in the cell membrane of neurons. And if it's spliced in this mean evil way, by beta and gamma secretase, a monofibril, an A-beta monofibril of a short amino acid sequence is liberated, becomes soluble, binds with other monofibrils to form an oligomer, and eventually forms in the amyloid plaque. This sequence of events clearly does occur in Alzheimer's disease. Somewhat debated still is whether it occurs and is etiologic or it simply happens to occur. But many people feel that either amyloid plaque or the process that results in its formation is toxic to nerve cells. There is a good role player, an alpha secretase, which splices this amyloid precursor protein in a way that prevents the formation of this monofibril and therefore the oligomers in the amyloid plaque. And people who express this enzyme more get amyloid plaque less and have Alzheimer's disease less. And the third part of the neuropathology is neurofibrillary tangles. As you may know, nerve cells have this one long branch, of course, the axon, and has cytoskeleton to allow the axon to stay competent, to stay structurally intact, and to function well and have stuff go back and forth, nutrients go back and forth in the axon. The part of that cytoskeletal structure depends on microtubules, which in turn depend on the protein tau. And when that protein is hyperphosphorylated, then tau does not work in the way it should, microtubules don't work in the way it should, and the nerve cell starts to become gnarly and not work well and die and fade away. And where those neurofibrillary tangles occur are where the symptoms occur. That is to say, you can argue that the symptoms of Alzheimer's disease correlate with where the neurofibrillary tangles are. Where you're missing cells is where you're symptomatic. Now you need both. It is not enough to have amyloid plaque. In order to have Alzheimer's disease, you have to have amyloid plaque and neurofibrillary tangles. So there is a continuum of the neuropathology certainty for this particular etiologic diagnosis. So if you had a biomarker of just neurofibrillary tangles, that's not enough to know that you would predict the person has Alzheimer's disease at autopsy. And if you have a biomarker of amyloid plaque, that is not enough to know that at autopsy you would expect Alzheimer's disease. At autopsy, Alzheimer's disease is based on the conjoint high presence of both species. Now we are now in an era where we can test for some of these things. There are markers for these pathologies. Interestingly, however, the markers don't change much while the patient changes. That is to say, there's a long period of time during which that pathology accumulates, and then something of a tipping point phenomenon, the person becomes symptomatic, often with little accumulation of any new pathology. So even though we have an era where we can do markers of neurofibrillary tangles and markers of amyloid plaque, those markers alone don't establish why the person is having symptoms. That's what we need a clinician for. Amyloid plaque is not specific to just Alzheimer's disease. If we do an amyloid brain PET scan, for example, and look to see how much amyloid plaque is in the brain, while Alzheimer's patients have a lot of it, so do normal elderly controls or people with Lewy body disease. So Alzheimer's disease is not established simply by having amyloid brain PET scans tell us about amyloid plaque, although it certainly makes Alzheimer's disease more likely. Similarly, neurofibrillary tangles are not only seen in Alzheimer's disease. There are other tangle-dominant dementia-causing diseases that are to some degree clinically and are neuropathologically distinct. So it's Alzheimer's disease if you have both a high burden of amyloid plaque and a high burden of neurofibrillary tangles in a person whose disease has behaved clinically in a manner compatible with Alzheimer's disease. What about treatments? Well, for a long time, we've had treatments for Alzheimer's disease, and I'm sorry, they don't do much. They don't do nothing, but they don't do much. So a disease like Alzheimer's that gets worse over time, what we'd love to be able to do is to cure it. If we can't, then even arrest symptoms or modify the disease course. But the medicines we've had up until recently are at most symptomatic. So I've shaded them all here in green. But then entering the fray last year is aducanumab, which purports to be a treatment that affects amyloid plaque by attacking the oligomer. And so it reduces amyloid plaque by stopping this phase. And as a result, the argument is this may modify the disease course itself. Very controversial drug. When it was approved by an accelerated pathway, meaning the FDA said, well, we'll give you 9 years to do a phase 4 study and really prove to us that it's going to work clinically, but we'll let you start using it. It's a monoclonal antibody to the A-beta oligomer, as I mentioned. It can only be given people early on because it makes no sense to give you a medicine that treats a pathology that's already removed so much of your brain that you can't function anymore. So it's only if it's Alzheimer's disease and if there's proof that the person has or is likely to have the amyloid pathology itself. Monthly IV infusions that are complicated by ARIA, as most amyloid treatments do, amyloid-related imaging abnormalities, because when you're pulling that amyloid plaque out, you can create some microhemorrhages in the brain, occasionally significant hemorrhages, and cerebral edema. Controversially, the drug was going to cost $56,000 a year, reduced later last year to the bargain rate of $28,000 a year. And then in January of 2022, Medicare said it was only going to be covered for people in clinical trials. These are the data, and this is the not controversial part. The drug definitely did, these data imply, remove amyloid plaque. So people with placebo, as they were measured over time, their amyloid plaque burden did not decrease. People who got the drug in a dose-dependent manner had a reduction in the amount of amyloid plaque. However, only one of the 2 large trials showed clinical improvement. On this particular graph, worsening is higher up on the graph. So placebo patients continued to worsen, and in one but not the other of the 2 trials, the patients on the drug did not seem to worsen quite as much. Controversies surround how this was arrived at and the fact that only one of the 2 trials showed that this clinical benefit was present. A new drug whose data was just released last month, called Locamumab, is going to be evaluated by the FDA shortly, possibly even just a few days from now. This drug also was shown to reduce amyloid plaque and was shown to have clinical improvement. On this data slide, it's better to have a number that goes down instead of up, as I showed with the other drug. So people who are getting, sorry, it's the other way around. So down is worse and up is better. So people with Locamumab had less worsening than people with placebo by, I think the data were 27%. Now, there are other drugs in the pipeline. Jeff Cummings, on an annual basis, puts out a paper like this, and he summarized in his most recent report that there are currently 143 drugs and 172 clinical trials for Alzheimer's disease, many of which are disease-modifying drugs that are in phase 3. But 83% of the drugs are in phase 3. So we're getting ready to have an explosion of drugs that are disease-modifying in the ways that those 2 other drugs have done. What that means is that the pressure is on you as clinicians to evaluate patients early, before they're too symptomatic, and while they may be eligible for the new drugs, regarding which you're going to have to now start to understand how to order and use biomarkers. By metaphor, you don't want to wait until after the bridge has collapsed to understand that there's metal fatigue. So the biomarker in this metaphor is the metal fatigue. And now we're supposed to be evaluating patients while the bridge is still up, or at worst, while it's sagging a bit. But once the bridge is down in the ravine, there's really no hope to bring it back up again. So we've talked about, I think, some ideas about how to be a cognitive neurology clinician. It starts by doing the work, using clinical judgment and insight to understand how the problem behaves, by getting information from the patient, from family, from observers, and from your own observations and your own neurocognitive testing. We've talked about how to use the right words to describe the phenomena you see and what clinical state is needing to be described. And I've tried to argue that what you're doing is applying a concept, a syndrome, something that you already do quite ably and without any controversy at all in everyday life and also in medicine. And we've talked about how to apply these concepts in the specific example of Alzheimer's disease. So I thank you for your time. And Danielle, I'm happy to answer any questions there may be.
Wonderful. Thank you, Dr. Shenker. This is Ben again. So we are kind of pushed up right against our time, actually. You used your time exceptionally well. I would just like to thank everyone for coming in here today and listening to our wonderful lecture. Dr. Shenker, thank you for taking the time to do so. Keep in mind that this webinar is recorded and will be on our channels here. You will find it on YouTube. We will post it on our website, and we will contact everyone through Synapse once that is posted. If you do have any questions that you would like to send to Dr. Shenker, you're free to contact us and do so. With that, everyone, thank you so much for being here. We'll be happy to host you again another individual next month. Wonderful. Have a great holiday, everyone.